After endocrine, we will start GI, so we have to do assessing patients with GI disorders, which is chapter 39 in your med-surg text and page 865. Page 865. Okay, we're in the GI system, so we need to focus on the GI complaints, often broken into upper and lower GI tracts, and so you can kind of see that from the different complaints individuals might have. We need to focus on the complaints that are listed here. We are, if you're following along in your book, we're on page 871. You guys can review the anatomy and physiology on your own. So look for these different complaints. Really focus on weight. Look for weight loss, weight gain in the past 6 to 12 months. Ask if it was intentional versus unintentional. Focus on their appetite, their ability to chew, swallow, and taste. What types of apparatuses do they have in their mouth? Bridges, braces, dentures. Do the dentures fit or not? Do they wear them? What kind of oral hygiene practices do they have? Do they go to see the dentist? You want to really focus on meds for the GI tract. This is where we talk about hepatotoxic drugs, which we've talked about in the past. This nice table on page 872 that outlines the most frequent hepatotoxic drugs that are given. You can see NSAIDs fall into this class, but also a lot of antibiotics. You also want to assess their use of antacids, laxatives, proton pump inhibitors, because those are mostly over the counter now. This kind of focuses a little bit more on the lower GI system, talking to them about their bowel patterns. I don't feel like we need to talk about that. You do want to note travel, especially if someone's coming in with a new history of diarrhea. You also want to assess for changes in diet, exercise, sleep patterns, fluid intakes. If they're having pain, is it upper versus lower? And if it's lower, is it rectal? And then get into what their stools look like. The main thing here is the stool. Has it changed shape? Has it changed consistency? Has it changed color? And then for upper, you want to assess indigestion. How frequent is the indigestion? Are there precipitating factors, the time of day, in regards to meal, before or after? You want to ask about any GI surgeries they've had, either upper or lower GI surgeries. Repair of a hiatal hernia, gastric resection, any type of bowel resections, hernia repairs, why they were done, when they were done, the outcomes. You also want to understand that the GI tract changes significantly as we age. There is a nice chart on page 871. You can read through these different changes, but you can see there's several areas that are affected. For instance, as we age, we have a greater tendency to lose teeth and have dental implants or have dentures. We have to be aware that weight loss or gain makes dentures fit improperly, so assess for proper fitting of dentures. As we age, we also lose our sense of taste, and so there's a decrease in the taste of food. Sometimes this leads the elderly to add excessive seasoning or even salt, and so we have to assess this. They also have issues with dysphagia, difficulty swallowing, more likely to have food trapped or stuck in their esophagus. They have slower movement of their gut, so movement of food through the small and large intestine slows down. They can experience fecal incontinence. This is not a normal aging process, but there are certain conditions that can lead to this. They have more difficulty with being gassy and having abdominal distension. And they can also suffer both in the large and small intestine with impaired absorption of nutrients, such as vitamins, fat-soluble vitamins. Listed throughout in the chapter are different genetic considerations of the upper and lower GI tract. And so you guys can look through these. Some of the ones that you can consider, there's a disease, abnormal copper accumulation, And that is actually Wilson's disease. So abnormal copper accumulation is actually Wilson's disease. It's genetic. Copper accumulates in the various organs. It's rare. There can be a family tendency to have hypercholesteremia. This is where you see it in young, healthy adults, and they have high lipid panels. So it's hereditary. It's much more difficult to control. Issues with fat metabolism can also be genetic, and so for Gutier's disease, for instance, that's a fat metabolism where the body's not able to break down lipids properly, and it accumulates in the cells and in the liver. That's genetic. Certain types of cancers, certainly colon cancer it tends to be like first line, so first relative for colon cancer. Cleft lip and palate, you guys will learn in pediatrics, has a genetic tendency also. When you look at page 872, it outlines the genetic considerations for colorectal cancer and inflammatory bowel disease. So that brings us to this slide. So ask about family history of irritable bowel disease, but also ask for a family history of what it's called familial adenomatous polyposis. And this is a picture of that. So if you look at page 872, it outlines what FAP is, and this individual has multiple polyps. They're essentially non-cancerous at first, but eventually they will turn into cancer. And so people who have a history of FAP have to have early colonoscopies, and essentially the only way to treat this is to have a colon resection. Okay, we're going to move on to assessment. So we're on physical exam, page 874. Remember, the techniques for a GI assessment include inspection, auscultation, percussion, and palpation. You can do the abdominal assessment in the supine position. Then, if needed, you can change positions. GI assessment should always include a height and a weight, which we've already talked about, and a calculation of BMI. Remembering that BMI sometimes are not accurate depending upon the individual, their body style. Athletes that have a lot of muscle tend to have abnormal BMIs. But for our purposes, less than 18.5 is considered underweight. So 18.5 to 25 is considered normal. Greater than 25 is considered overweight. And greater than 30 is considered obese. So we can calculate BMIs based upon the patient's height and weight. Start off with an assessment of the mouth, just looking at the tongue, making sure there's no lesions on the tongue. Obviously, you can have gloves on, and you can pull the tongue out and look at it from side to side. If you see any lesions, if you need to know if they're hard or not, you can palpate those. Looking at the overall mucosa, looking inside the mouth, lesions, any ulcerations, any discolorations, loose teeth, what do the gums look like? Are they receding? Also looking at the throat, is it red? Look at the tonsils, present or not present. And note the breath. We can tell a lot about a patient's breath. And also you want to, at this point, you can palpate the lymph nodes of the neck.